Thank you for this invitation. This is a case for intracardiac migration of Vena Cava filter. I don't have disclosures. It's a 56-year-old male patient with gastroduodenal ulcer with active bleeding. In the hospitalization, he complains left lower leg pain and edema. The physical examination on Doppler ultrasound reveals deep venous thrombosis. The staff decided the patient has a contraindication to any coagulation and he needs a retrieval Vena Cava filter. And the procedure done the next day. Without complications, by femoral approach, Vena Cava diameter 22 millimeters. It was a normal infrarenal vein deployment of a Gunter tulip Vena Cava filter from Cook, and angiographic control post-deployment is normal. We scheduled the patient in 3 weeks to retrieve the filter. And you can see, this is the venogram. You can see the renal veins and the Vena Cava and the good position on the filter, infrarenal position. But 3 weeks later, we were looking the filter to retrieve, and we found the filter in the heart on the tricuspid valve that you can see the video. And on the tricuspid valve, where we decide use the endovascular approach to retrieve the filter, and you can see the same retrieval set, the catheter and the snare, and we took the hook of the filter in this position and we pulled down the catheter to the groin, and the filter were inside the catheter. This is the filter, the Vena Cava filter, completely destroyed. And you can see here in this picture the catheter and the snare and the filter destroyed. The intracardiac migration of Vena Cava filter is an extremely rare complication, and uncomplicated cases can be removed by endovenous approach. But normally, this migration causes pulmonary embolism, ventricular arrhythmia, and paradoxical embolization. The indications for retrieval of IVC filters. The appropriate indication is a temporary contraindication to any coagulation, and potential indications prophylaxis, high-risk trauma patients from lysis and pregnancy, for example. And the complications to Vena Cava filters is a complication from insertion 4 to 11%, IVC thrombosis 6 to 30%, filter migration 3 to 69%, and IVC perforation 9 to 24%. What is the etiology of migration of Vena Cava filters? Dislocation, strut fracture, inadequate diameter of inferior Vena Cava, more than 30 millimeters, accumulation of thrombi, and failure to opening legs of the filter. In chest, we found a paper. It is a review of published data in intracardiac migration of inferior Vena Cava filters, and you can see that in almost 66 patients, 22% were asymptomatic, and 25% with the patient on the tricuspid valve, 45% in the pulmonary artery, and a hypotension with 22% of patients. This paper is 2009. And this paper, the endovascular retrieval of intracardiac inferior Vena Cava filters, a review of published techniques. You can see the previous technique to retrieve the filter. This is the special catheter to 24 French to access to the jugular vein. And this is the Yates technique, we use this technique by femoral approach. This is the catheter, this is the snare, and we catch the hook of the filter and we pull down the catheter in this procedure. So what did we do wrong? The diameter of inferior Vena Cava, technique, fracture, failure to open the legs of the filter, and almost 40% of cases there's no explanation. In conclusions, Mr. Chairman, the migration of intraferrinal vena cava filter is a rare complication but may be fatal. Intracardiac migration is extremely rare and 20% of patients are asymptomatic. Most of patients have high mortality for pulmonary embolism, electrophysiology, alterations of the heart, and intracardiac vena cava filter can be removed by surgical way or by endovascular techniques, but sometimes the percutaneous approach can be challenged. So we need to deploy on vena cava filters training, materials and equipment, diameter of vena cava, always measurement, venogram, control after deployment, and follow-up. Thank you.